So hello everyone and welcome to this case 27 of this case discussion series, and today we'll be discussing a very interesting case and a bit complicated one. So here we have an 80-year-old female known case of chronic lymphocytic leukemia and a thyroid malignancy who came with complaints of difficulty in breathing, and this is the MRI done for this patient. These are the T1 axial images where we can see that there is a mass lesion occupying the nasal cavities, the nasopharynx, the cavernous sinus, sphenoid sinus, and also the posterior fossa, which is iso-intense on T1 as well as T2 weighted images. These are the axial sections T2 weighted images, and it has some mass effect on the optic nerve. It is homogeneously enhancing with no areas of necrosis. These are T1 coronal images where we can see this entire extent of the mass. These are extraaxial posterior fossa is also involved. There was no restriction on DWI or blooming on the GRE sequences. So this is the report that I had given. It was actually a very extensive, very big mass and was occupying so many areas. There was an ill-defined mass lesion involving bilateral nasal cavities, nasopharynx, ethmoid sinus, sphenoid sinus. The lesion appeared iso-intense to grey matter on T1 as well as T2 weighted images with intense homogeneous post-contrast enhancement. Superiorly, the lesion involved the base of the skull including the clivus and extended to involve the sella as well and the cavernous sinus. Laterally, the mass lesion was compressing the intraorbital optic nerves anteriorly, and because of that she was not able to see. And then it was also encasing bilateral intracavernous ICA with no significant luminal narrowing. Posteriorly, the mass lesion involved the dens of the C2 vertebra, which was seen on the sagittal images, and also it extended to involve the left tentorium, left jugular fossa, the extraaxial left posterior fossa, causing mild displacement of the adjacent left cerebellum. The lesion did not show any restriction on DWI or blooming on GRE sequences. There was no evident involvement of the brain parenchyma that was seen. There was also a filling defect in the left sigmoid sinus, which was suggestive of a dural sinus thrombosis. Features were suggestive of the leukemic infiltrates in the brain. A heterogeneously enhancing oval lesion was also seen in the left parietal calvarium on the sagittal images, which was suggestive of metastatic deposits. There were some ischemic changes which were seen on T2 and FLAIR in the brain. So what are the CNS manifestations of leukemia? The leukemia CNS manifestations can be divided into two CNS manifestations directly attributed to leukemia and those because of the treatment of the leukemia. So directly attributed to leukemia include leukemic meningitis, intradural spinal involvement, granulocytic sarcoma or chloroma, which is particularly seen in AML. And then hematological and cerebrovascular complications include cerebral hemorrhage because of DIC and dural venous thrombosis, which was seen here. Infections due to immunosuppression include CNS aspergillosis and candidiasis. Then bone marrow infiltration, fat is replaced by leukemic elements, and ocular manifestations include leukemic infiltration of the optic nerve and retinal hemorrhages. Coming to treatment related complications, which include PRES, that is posterior reversible encephalopathy syndrome, which is chemotherapy induced, methotrexate toxicity, radiation induced neoplasms, and so on.